the times, so, majority, sorry. So, so majority of the times we miss like some of the heart diseases which are labeled as dilated cardiomyopathy, and unnecessarily we are subjecting them for transplant list. But majority of the times in children, particularly in children, they are all having some underlying heart disease which are usually treatable. So these costly misses in the infantile period or in the pediatric age, if you miss it, definitely we are going to lose the patient, or we are going to subject them for transplant. So here I am going to discuss in a clinical scenarios. So here is a 4-month female child presented with viral prodromal symptoms. On examination, child is having failure features with X-ray showing cardiomegaly. So if done elsewhere, it was showing that severe ventricular dysfunction. So viral myocarditis was suspected. So in a 4 months child, that means in the first 6 months of age, any child presented with congestive cardiac failure without previous any significant history, we always better to evaluate for the underlying heart disease. So so the next choice what we do is, as a periodic cardiologist or as a cardiologist, always our diagnosis will not be completed without doing an ECG. So if you see this ECG, there is a deep Q waves in L1, sorry, in 1 and AVL and with the chest leads also. So we are now damn sure that this is a case of left coronary involvement, that is called Al-Kappa. Okay, you can see that there is. So this is the aortic annulus, this is the pulmonary. So the pulmonary artery is getting the coronary involvement. So the LAD and LCH are directly going into the pulmonary artery. So in the first 3-4 months, they will, because of high PVR, sometimes they may not be identified or may not have any manifestation. But later, after 6 weeks, usually they will start having symptoms. So the first thing we should have in our mind, whenever you are seeing a global hypokinesia child with ventricular dysfunction, just check for the papillary muscles. So if there is any echogenicity, hyperechogenicity, that is showing that most probably it is an Al-Kappa, and then you will have to look for the direction of coronary arteries and their insertion in the great artery levels. So whether it is inserted into the aorta or into the pulmonary artery. The second scenario is the 11 months female child brought with history of fever from 10 days. So because it's a 10 days history, so majority of the times they, in the less than 1 year child, majority of the times they treat like a sepsis. The pediatrician was treating, considering as a sepsis. But because the cardiovascular system doesn't show any significant history. The cardiac sounds are normal, there is no significant murmur. But when lab investigation showed there is a significant anemia with leukocytosis and thrombocytosis, the inflammatory markers are grossly elevated. So it is a rule that always in less than 1 year, whenever any child presented with history of fever for more than 7 days, you have to rule out Kawasaki disease, even though there is no other lesions. So this child is having significant manal edema and there is a perianal excoriation. So it's a classical case of Kawasaki disease. So we can see that there is the significant dilated coronary artery. So, but always the significance comes when you see for the G scores. So here the left main coronary artery is having a G score of plus 7.3. So this is indicating that it is a Kawasaki disease. So the other miss spot here is this child started on IVIG. Immediately the child had deference, so they left. But follow-up was mandatory, but they didn't come. After 2 months, the child came for review. That time we saw this. Again, you can see that. So there is a significant, large giant coronary aneurysm of the left main coronary artery and the LAD territory. So what we missed here is, so this is an angiogram, but this is not immediately after 1 month. This is after 6 months. So you can see that right coronary artery is okay, but the left main territory is having giant coronary aneurysm with stenosis. So what else could be done to avoid this? So whenever you are having a Kawasaki disease, particularly less than 1 year child, say there is less than 6 months, but it is we always in Indian scenario less than 1 year. Always it should be managed with triple therapy, that is IVIG, even Fliximab and steroids. And other indications which needs for triple therapy is grossly elevated CRP and hypoalbuminemia, transaminitis, and anemia, low sodium levels, and high neutrophil percent. Just for confirmation, completion sake, I'm giving this. So less than 2 G score means there is normal coronaries, and 2 to 2.5. It can be atypical dilatation. Sometimes you can see in viral infection. 2.5 to 5 is a small aneurysm. Less than 8 mm or 5 to 10 G score is medium aneurysm. And more than 10 or more than 8 mm is a giant coronary aneurysm. So babies needs to be on lifelong anticoagulation unless it comes down the G score less than 2.5. And learning points here is needs close follow-up and warfarin INR and dual antiplatelets with INR monitoring. And definitely all these patients, though there is less chances for atherosclerosis, still we have to start on statins, yearly monitoring of ECG, post-stress test depending on the age of the child. The third scenario is a 14-year male child with hemoptysis. So there is a grade 3 clubbing all and saturations were 80 to 85%. So as a routine, everybody suspected it's a cyanotic congenital heart disease. But echo was showing outside it's a normal state. The pediatrician sent the X-ray of the child. Means this is not like hypovolemia, but it is not like hypovolemia. There is plethora is there. Here a point which is showing us is homogeneous consolidation at this area. So I asked the pediatrician to do CT and send them back. This is nothing but the pulmonary AV fistula. Okay? It's the pulmonary AV fistula, so which has a treatment. Means so this one we did here this one we did with the 2 device closure, larger one. One is with the 22 amperature vascular plug and another 18 life tech 1 RMF device. We did the saturation improved from 80 to 85%. Few days into 95%, and now child doesn't have between clubbing. So here another point is there is a family history of intestinal polyps in the another sibling. So it is the hereditary hemorrhagic telangiectasia case. Last scenario is a 13 years female child with class 3, class 4 symptoms since last 4 months. So elsewhere it was diagnosed like LV dysfunction, and there is means labeled as idiopathic dilated cardiomyopathy. So they started the conventional treatment, but when we saw the child definitely having significant LV dysfunction with EF of around 15 to 20%. But there are 2 other supporting points actually. So there is a significant aortic regurgitation and there is a turbulence in the descending aorta. So this is nothing but the Takayasu arthritis. So most of the time this is the on follow CT angiogram. So showing significant stenosis. So this when we did, so always whenever you want to do, so you have to complete with the routine blood workup, so which showing grossly elevated inflammatory markers. Then suspecting them like only it's a cardiomyopathy, it's not paid. So you have to this one child on rheumatologist opinion with steroids and immunosuppressants. So we are waiting for this child for aortic stenting. So temporary balloon dilatation done because the child is only 13 years. So that child is also having significant hypertension, but it's managed with routine antihypertensives. So before concluding, I want to label this. So always, whenever you are having any suspicion, conditions like so never ever judge like this is an idiopathic dilated cardiomyopathy before labeling it as. You have to roll out these things, particularly in pediatric population. So first thing is Al-Kappa. Whenever you are having a doubt, so first get an ECG done and high resolution echocardiography. And if you are still in a dilemma, either coronary angiogram or CTCAG will help. And tachyarrhythmias, particularly like PJRT and ectopic atrial tachycardias, definitely they'll have this tachycardiomyopathy. So ECG and Holter monitoring is going to help you. And other thing is coarctation. Majority of the times you might miss coarctation because of collaterals, and some majority the suprasternal views may not be available in children. So, but you have to have a detailed physical examination, so the differential pulse pressures and echo, and if at all required, if you are not sure and if you have a short neck or something else, you are not able to pick the upper the ascending aorta, sorry, ascending means arch and descending aorta, then you have to subject them for CT. And arthritis, here also the echo and if at all required CT or MRI. And in children, particularly in Indian scenario, majority of the times they will have only maternal vitamin D deficiency, so which can lead to hypocalcemia and LV dysfunction. So these things actually you can pick up with routine blood picture, and this one sometimes in bizarre QRS complexes with ST changes, that also suggestive of hypocalcemia. So, and systemic hypertension, though little rare in children, but still is a reason for dilated cardiomyopathy. So if you start on antihypertensives,